Okay, welcome to this next session of the Presidential Symposium. I'm Ted Siegel. I'm an associate professor in the engineering department and one of the symposium committee advisors. In this session, the School of Health Sciences presents the beauty of art therapy through time, research, and its application with veterans. During this session, panelists will reflect on how art therapy serves as both a clinical tool and a source of inspiration, helping individuals communicate experiences that words often cannot capture. Special attention will be given to the role of art therapy in diverse settings, including mental health, higher education, and work with veteran populations. At the end of the session, there will be time for a Q&A, and we would like you to please use the microphones that are located in the aisles while asking your questions. The moderator for this session is Morgan Gatos, Adjunct Assistant Professor of Counseling and Mental Health Professions. Professor Gatos, the floor is yours.
Thank you. Thank you. Hi. I'm much shorter. Welcome, everyone. This turnout is really exciting, and we are so happy to have our expert panels to discuss this topic, to see our students, our colleagues. I won't take too much time. Right now, I would like to invite our first panelist up to the stage, Dr. David Gusak, who has taught for the Florida State University Art Therapy Program for more than 20 years. 10 of those years, he also served as the chairperson for the university's Department of Art Education. Dr. Gusak has more than 30 years of clinical and practical experience. This includes various forensic systems, several correctional institutions and settings, and a private practice. This has led him to recently transition into the role of program coordinator for the FSU's Department of Corrections Art Therapy in Prisons program, where he will continue to share his expertise in the forensic continuum. I see you there. Additionally, Dr. Gusak has almost 50 journal publications and chapters and has authored 3 of his own books between the years of 2013 and 2022. He has also co-edited the Wiley Handbook of Art Therapy, first edition, and very recently, the second edition will be published very shortly and out for review. He currently sits on the editorial review board for Art Therapy, Journal of the American Art Therapy Association, and the Arts in Psychotherapy, as well as being a frequent guest editor for the International Journal of Offender Treatment and Criminology. Dr. Gusak is also the co-editor-in-chief of the new International Journal for Creativity Inside, and most recently, in 2022, was granted the prestigious award of the American Art Therapy Association's Honorary Lifetime Member. Welcome, Dr. Gusak.
For those of you who don't know, art therapy, how many of you know what art therapy is? It's specifically therapy with people named Art. Just so you know. We're thinking of expanding the field to include people named Drew and Clay. Not so much? All right. That one was funnier in my head. All right, so I'm here to talk about the history of art therapy, particularly over the past 3,000 years. That's right. And so, is it beautiful? Is art therapy, the history of art therapy, beautiful? Sure, why not? Is it ugly and messy? Maybe. Let me explain. No, there's too much. Let me sum up. Really? Are we that far removed from The Princess Bride? That's a funny line. All right. Let's go back 3,000 years, a very long history of recognizing the benefits of arts and healing. We go back to when we recognized that dance, music, and art were often used in rituals for healing. Drawings were used as wish fulfillment, imaginal practice for getting ready, for practicing and getting ready in the mind's eye. We recognize this gentleman in Imhotep. Back in 3000 BC, he used to prescribe art activities for depression, including painting, drawing, dancing, and reading. You have to imagine this. He was prescribing this on these hieroglyphics. Doctors still write in hieroglyphics. It's fascinating. We recognize, of course, that no matter how much he self-prescribes, he doesn't look so good these days. But then we're going to go ahead and fast forward to about, back to the 1920s. We're familiar with Sigmund Freud, right? He's credited for being the father of modern day psychology. We really don't know if that's the case. There's never been a paternity test, but we do know. Wow. You know what I'm excited about? I'm actually from New York, but I live down in Florida. And when I'm in Florida, people can't keep up with the pace of the way I speak. So I was very excited about coming up here to be able to speak with all of you. And perhaps all of you can jump in. We also recognize, of course, he came up with the Freudian slip. Those of you who don't know what a Freudian slip is, it's when you say one thing and you mean a mother. So Freud often used images as a means of understanding the client's mind. Of course, Carl Jung took it one step further. He had clients draw dreams in and out of therapy. He also studied the value of symbols from cross-cultural perspectives. We can jump to Hans Prinzhorn. Hans Prinzhorn was actually the medical director at Heidelberg Mental Hospital, and he collected the artwork of over 5,000 drawings of his patients and started to categorize these and recognize the relationship to the images to the actual illnesses that they had. So he actually started the process of assessments to recognize that certain characteristics of art were part of the characteristics of certain mental illnesses. So for those students who are in assessments class, it's his fault. We could also recognize Fritz Perls. I included him because I wanted to finish the line of the old white men to show that this is the early steps of art therapy. He was actually a Gestalt psychologist, which actually informed a lot of our understanding of wholeness. And Janie Ryan actually studied at the knee of Fritz Perls. We're going to jump ahead now to the beauty of some of our founders of the field. This is Margaret Naumburg. Margaret Naumburg met John Dewey at Columbus College, and met Montessori and studied on Montessori in Italy. She studied under Adler and founded the Walden School in 1915 right here in New York City. Her philosophy was the importance of addressing the unconscious through education, but she believed, this is really cool, she believed that the best way to do this was through art expression. So she's hired her sister Florence to teach at an art program at Walden School, and she developed what's known as art psychotherapy. Now, essentially, what art psychotherapy is that we recognize that art can be used as symbolic communication between the patient and the therapist. It is actually a focus on the product of the art. So once a piece is finished, we can use that as a means of communication, of connecting to our clients. We also have Edith Kramer, who actually didn't get along with Margaret Naumburg. We have a field where there's a lot of interesting dynamic arguments. And Margaret and Kramer actually did not get along. But Kramer believed, this is not true, this isn't about the product, it's actually about the process, the art making, it's art as therapy. And here she is saying, so on one hand, I'm just gonna get out here. Okay, can you hear me? No. Okay, good. You can't hear me? Okay, so I have to stand here? All right, wow, that was fun. All right, so we have on one side, we have art as product. On the other side, we have art as therapy. We went like this for like 10, 15, 20 years until along came Eleanor Ullman. And Eleanor Ullman said, actually, it depends. It's the synthesis of the two where the art therapy happens, depending on the needs of our clients. Sometimes we focus on the product, sometimes we focus on the process. For example, I specialize in working in correctional environments. I work with forensic populations where any disclosure of vulnerabilities and weaknesses may be taken advantage of by others. So it's important for us to be able to leave that mask in place to work behind it. So it's the process of the art making that's so important, right? Now, around this time, around the 1960s, we have Myra Levick, who was working on the East Coast in Philadelphia, and she started writing about the value of art and art therapy. Separately, we have Don Jones and Bob Alt, who were at the Menninger Clinic in Kansas. Now, everybody here, up at this point, they believed that what they were doing was isolated from each other. They thought that they had something special, that they didn't know that there were other people out there that really were engaging in the value of art making until they read an article published by Eleanor Ullman about the value of art therapy, and they started talking with each other. And along came Felice Cohen. And between the four of these people living all over the country, they decided to come together and form the American Art Therapy Association in 1969. Right? So here we have ADA, and this is the way it looks now. And around the same time, around the summer of 69, right? Sorry. No, not that person. Sandra Graves. In 1969, Dr. Roger White at the University of Louisville, who was a psychiatrist, invited Sandra Graves Kagan to campus to talk about reviving courses that had been on the books since the 50s. So at about this time, Sandra attends the first meeting of the Art Therapy Association in 1969, and she is credited with starting the first art therapy program. That is at the University of Louisville. So if you're from the Midwest, you actually believe that the first program started in Louisville. Of course, if you're Myra Levick and you're in the East Coast, you believe the first program started at Hahnemann. So that's an interesting debate. But regardless, at this point, we're starting to realize that there's a need for education, that we need to start informing people about the intricacies and the value of art therapy. Also around this time, we have Cliff Joseph. He attended the first ADA meeting in Kentucky. He's one of the first African-American art therapists, and he emerged as one of the most dynamic advocates in the field throughout the 1970s while teaching at Pratt University, and really started the social justice paradigm. We think that the notion of social justice in our field is fairly recent, but this goes back 40 or 50 years. Cliff Joseph started it all, and he's just an incredible person. I would urge you all to go ahead and Google the YouTube video where Barbara Fish interviewed Cliff Joseph about the value of art and art making. It was amazing. Also, we recognize that although we have the American Art Therapy Association, each state is different. And so as time is developing, they decide to start creating affiliate chapters. So the very first Art Therapy Association chapter was the Wisconsin Art Therapy Association, founded by Wayne Ramirez from Puerto Rico. And there's, again, a big discussion whether or not WADA came before ADA. Apparently, that's a big deal. But essentially, at around this time, we started organizing. You have to imagine this, right? We're artists, and we're trying to create an organization and work together to see the value and benefits of art therapy. Lucy Ventura, co-founder and first president of the Maryland Art Therapy Association, was the first person in this new profession to earn a PhD. You have to understand that around this time, the terminal degree for our field was a master's degree. There were people that were getting PhDs in completely unrelated fields. I would argue that all of us who are here who have PhDs, completely unrelated, right? It's only been in the past 10, 15 years that we've developed these really strong, robust PhD programs. And I say that because one of them is actually at Florida State. So I expect to see all 40 of you who are there on the right-hand side eventually at Florida State. So we'll sign you up later. Our first conference was held in bustling Warrenton, Virginia. Now, here's an interesting thing. Margaret Naumburg was 5 minutes, yes. No, I got it, thanks. Margaret Naumburg actually was awarded the first honorary life membership back in 1969. Here's why, and I was explaining this to Deb earlier. Margaret Naumburg, who was one of the founders, considered the mother of art therapy field, didn't believe in art therapy being its own field, didn't believe it should have its own organization and be a standalone profession. And so she refused to be a member of the American Art Therapy Association. So the American Art Therapy Association said, fine, we're going to give you the first honorary life membership award, so you have no choice. So Margaret Naumburg was the first HLM. So the HLM designation is a little bit questionable. So it started back in 1969. Immediately, 3 issues emerged. One was the definition of art therapy, right? If you put, 10 art therapists in a room together, and all of those art therapists will say that what they do is successful, but what they do and how they do it is completely different from each other. So all of us have created this vast understandings of what art therapy is. That included where are we along the continuum between the psychotherapy and artist therapy? And of course, who can call themselves an art therapist? Standards of practice were developed, which led to the types of training or educational programs, which included programs like Hofstra University, George Washington University, and Vermont College. 1990s, credentialing of art therapists became even more important. We were receiving the ATR back in the 70s, started recognizing the need for standalone credentials. That developed in the 1990s. Some of us took that first exam. We still have flashbacks. Some art therapists actually wanted to be certified, only a few did, but they developed this national certification exam, and ATCB was developed and began to oversee the credential that same year. Over the years, we have stood on the shoulders of what came before us, and we have continued to evolve. We expand the definition of what art therapy is, increasing the number and robustness of its reach, increasing the robustness of the training programs, developing strong interdisciplinary relationships, developing these doctoral programs, and you'll see here the far outreach of the research that we do and the different programs that we offer. The fact that all of us now are providing art therapy in a vast arena in different settings. We continue to evolve, yay. And just to give you an idea, right, I've been teaching history and theories of art therapy class for more than 30 years. And every few years, that section of the class gets longer and longer. Because quite frankly, as we continue to evolve, we continue to make history to add to what we've done. The history is never going to be over. And I dare all of you to continue moving that history forward. What you're going to hear from the rest of our panelists is how they continue to move that line. Thank you very much. I appreciate your indulgence, and I look forward to answering your questions.
Thank you, Dr. Gusak. That was the tiniest little nutshell of the history. And I encourage you all just to really be curious and to learn more. Our content will build, and another aspect that is really important in the field, which our next panelist, Dr. Sojung Park, is going to speak about, is that of research and the beauty of research, which is very different when there is artwork involved. Dr. Sojung Park has over 2 decades of clinical experience working with individuals with mental illnesses and addiction within the United States. Upon moving to Korea in the early 2010s, Dr. Park has dedicated herself to teaching and training future art therapists at the Ewha Women's University in Seoul up until she returned to the United States in 2022 to continue her endeavor as an art therapy educator. As a researcher, Dr. Park has explored multiculturalism, interculturalism, psychiatric and/or addiction, and community-based practice and social action within art therapy from both qualitative and art-based research paradigms. She is a recipient of the 2022 Best Paper Award from the Journal of the American Art Therapy Association and the 2020 Pearlie Robertson Scholarship Award for her research project which targets multicultural aspects and capacities of art therapy. Dr. Park is an active member of the editorial board for the Journal of American Art Therapy Association, part of the Multicultural Committee, and is also one of our full-time faculty members in the Creative Arts Therapy program. Dr. Park, welcome.
Hello, everyone. Thank you for the opportunity to share my perspectives on art therapy research and the beauty it holds. Like many other social science fields, art therapy has a wide range of research. Regardless of the methodology, I find the theme of today's symposium, beauty, to be particularly fitting because in a broader sense, art therapy research is really about studying the beauty that art brings to people's lives. And it's also about growth. Research in general is often seen as boring or intimidating, especially by students. I see some of my students sitting over there, and I know. And I understand why, because it can look dry and disconnected from real life. But when we approach it through the lens of beauty, research is anything but dull. Honestly, I never thought that I would be saying this when I was a student, but now I find research fun and creative. So let me explain why. So I see research as a way to connect with the world And to be more specific, I believe research is how we engage with the world through questions, which is at the core of being humans. And as Einstein said, as human beings, we must not stop questioning because curiosity has its own reason for existing. And on top of being questioning beings, one of the privileges and sometimes the burdens of being an art therapist is that we constantly hold questions in our minds. And I do too, but do not worry, I'm not going to share the full list today because some of them you don't want to know, trust me. Since I became an art therapist, I've been deeply curious about people's lived experiences, the fundamental meanings they hold, and how art, especially art therapy, can transform lives. And that curiosity naturally shaped my path as a qualitative and arts-based researcher. So today, I want to share how the questions I hold as an art therapist and as a person turn into research questions and why it excites me so much, because it really does. One day, I wondered, what actually makes research enjoyable for me? What was the study that I enjoyed the most? And luckily, a few came to mind, and I'll briefly share two of them with you today. The first is a phenomenological study I conducted a few years ago with a former student of mine in Korea. It explored community-based art therapy that fostered coexistence between South Korean teenagers and North Korean youth defectors. The second is an arts-based inquiry on a roundtable discussion among South Korean art therapists about racism and ethnic discrimination. And as I reflected on why these studies were meaningful to me in particular, I realized that they both connected deeply to my own existential questions about my place in the world. For example, coexistence has become an important topic for me. I'm originally from Seoul, Korea, and during my graduate studies in the US, I lived as a cultural minority, navigating life in a language that was not my mother tongue. By the way, I love this country before we move forward, just to be clear. But when I returned to Korea, I automatically became part of the majority again. And it was comfortable to be in that position of power, but soon that comfort created an inner conflict because I remembered what it was like to be on the other side. And this conflict led me to what Dr. Martin Luther King Jr. said, so maybe we can read this together. We still have a choice today, nonviolent coexistence or violent co-annihilation. This may well be mankind's last chance to choose between chaos and community. And this really inspired me that I had a choice to utilize art therapy as a way to support coexistence within communities, especially knowing how social conflict can deeply affect individuals' mental health. I thought about groups in Korea with the most tension, and North Korean defectors came to mind, considering complex cultural histories and the social tension. So I partnered with one of the few alternative schools in Korea, which openly makes South Korean teens and North Korean youth defectors in the classroom. And they supported our proposed study to run a community-based art therapy program, aiming to see how these groups of teenagers might find their own way to coexist without adults telling them how to, like we know any better. So we created a semester-long after-school program called the Village Making Project, and 8 students who barely knew each other participated. And the results show the process of how they were able to learn to coexist through collaborative artwork. When students first created characters to represent themselves to live in the village, they discovered new aspects of who they were. And by designing personal space for these characters, they were able to recognize what they truly valued. By defining themselves, students began to notice others with both similar and different values. They learned not only to understand and accept each other's desires and differences, but also to embrace the challenges that sometimes came with them. Finally, through this process, students developed a sense of we. They took responsibility for communication and worked together to find answers and discover that some things are better when they choose we over I. At the end of semester presentation, the students shared the village they created together and their definition of coexistence with the entire school community. And one student said, coexistence is when people from different backgrounds gather in the same space and stay together. And this moment reminded me of what coexistence truly means, and it continues to guide my research today. So while the first study highlighted the beauty of coexistence, I was also confronted with moments of division in our world, something that we can't ignore although we try. And the second study arose from such an experience. The study began with my reaction to the rise of anti-Asian hate crimes in the United States after the COVID-19 outbreak. I was in Korea at the time, but hearing about what was happening in this country was deeply unsettling, as I could relate to the experience of being a cultural minority in the US again. And this reminded me how often Asian voices remain unheard, not only because conversations about race in the US are so often framed around black and white experiences, but also as scholars have long noted that this invisibility has been a persistent reality in broader discussions of race. But what struck me, however, was how indifferently people in Korea reacted. And since we make up the majority there, many seemed detached from the issue of anti-Asian hate crimes in Western countries. And some even appeared indifferent because simply it didn't affect them directly. And this led me switch my perspectives and reflect on the forms of discrimination within Korea, a society long perceived as a mono-ethnic, where prejudice is often directed toward other Asian ethnic groups, causing various levels of social issues. And this further prompted me to recall my own shifting racial and ethnic identities between Korea and the US. And I realized that my political stance, for instance, conveniently shifted depending on whether I was in the minority or majority to serve my own benefits. And this realization humbled me and made me curious about how such experiences parallel and shape the way we view others. So from this, my research question emerged. I wanted to know how South Koreans navigate our social positions being part of the majority at home, yet a minority abroad. I also sought to explore the paradox that while Asian voices often remain unheard in the United States, in Korea, we ourselves sometimes silence the voices of other ethnic communities. So together with 3 research partners who share similar experiences, we created a series of artworks to explore this shift. And using arts-based research, we tried to capture our experiences from both ends, which are often nonverbal, as vividly as possible. Our findings highlighted parallel experiences of moving between minority and majority positions across the 2 countries. When we reflected on the personal meaning of anti-Asian racism to us, our artwork showed that it meant forcing us to live with invisible identities and hidden struggles. As minorities, we encountered prejudice in everyday interactions at school, restaurant, and even on the street, constant microaggressions and systemic racism that reminded us of our marginal status. And these experiences made us feel unseen, yet heavily affected by the structures around us. On the other hand, when we were in the majority position in Korea, we recognized something different. It was easy to benefit from unity in discrimination. We noticed how Korean supremacy could be reproduced, not always intentionally, but through ignorance or even a false sense of innocence. Although some of the findings made us uncomfortable, they naturally led us to reflect on our roles as art therapists and how we need to actively create spaces for reconciliation, solidarity, and humanity. Accountability, which is the willingness to bear responsibility, was also emphasized for art therapists to bring meaningful change, while maintaining a balance between majority and minority identities. So although this study was conducted within the cultural context between Korea and the US, I believe the implications extend more broadly, combined with the first study I shared. Each of us carries both majority and minority identities, and these are not fixed, but shift across context and over time. By recognizing this fluidity, we can draw on our own experiences to better understand and support others whose perspectives and values may differ from our own. By sharing these studies, I hope you can see how my research reflects my worldview and carries my ontological voice, not only as a researcher, but also as a practitioner and as a person. As I mentioned earlier, I'm naturally drawn to methodologies that share the narratives of participants and at times my own, both verbally and visually. By retelling these stories through research, I feel nurtured by the beauty of new insights and knowledge that shape my perspective on life. And there's also beauty in sharing research with others as it invites them to join me in this enriching experience like today. And it is how I connect and give back to the community. So we as researchers are never isolated from the communities in which we work. And we're always shaped by the results of our studies. So for me, this process brings joy, purpose, and fulfillment. I believe that art therapists are truly fortunate to walk this path through the medium of art, which reveals the true beauty of human life that is often unspoken. Thank you.
Thank you, Dr. Park. The relationship between research and the community is just so important. It provides us with another platform to have individuals really establish their voice and to use their voice through creativity. So we're going to switch gears slightly and welcome Fred Skanga to the stage. He is a board-certified healthcare management and licensed nursing home administrator who is the current executive director of Long Island State Veterans Home and Stony Brook University. And he has also witnessed the power of art and art therapy with the residents at this setting. Frank has worked in a variety of senior level healthcare positions in academic medical centers, community hospitals, long-term care facilities, and physician practice management. He also serves as an adjunct professor in the graduate healthcare administration programs at Hofstra University and Stony Brook, where he lectures extensively on the topics of healthcare leadership, long-term care management, and ambulatory services. In addition to other faculty roles in the greater New York area, Fred serves as the first vice president for the National Association of State Veterans Homes and is a board member of the National Council of Certified Dementia Practitioners. Fred has numerous awards, including the 2000 Award for Distinction from the Metropolitan Health Administration Association, the 2004 Community Recognition Award for the Veterans Administration, the 2005 Man of the Year in Healthcare Award from Stony Brook, and the 2008 Master of Health Administration Program Professor Award from our very own Hofstra University. And Fred, you shared that you just won an additional award.
2025 Advocate.
2025.
Veteran Advocate of the Year.
Welcome. Thank you so much for your work.
Thank you. Do I advance to the slide?
Yep. You just push right over.
Thanks so much. It's a real pleasure for me to be here. I'm probably the only non-art therapist on the panel, but my perspective is as a healthcare executive for over 40 years, of which the last 25 I've had the high honor of serving as the executive director of the Long Island State Veterans Home. For those who don't know, at this moment in time, we have about 15.8 million veterans in the United States. Are there any veterans in the room right now? Can I ask you to stand and be recognized? Thank you for your service. Closer to home in New York State, we have about 800,000 veterans in our state. And here on Long Island, we have about 80,000 veterans, but I'd like to give you a little perspective on that. As when I began my career at the Vets Home in Stony Brook, in 2001, we had about 200,000 veterans here on Long Island. That number has decreased to about 80,000. I think a big part of it relates to the passing of many of our World War II veterans who came or were born in the 5 boroughs, migrated to Long Island, lived their lives, and eventually came, many of them, to my state veterans home. But out of the remaining 80,000 veterans on Long Island, 2/3 of them are over the age of 65. So just a perspective. So right now, I want to give you a little perspective about what I do in terms of a state veterans home. We're often confused as being part of the VA, the Veterans Administration, but we're actually not part of the Veterans Administration. For those who might remember Abraham Lincoln, number 16, as I call him affectionately, we had a civil war going on in this country, and we lost about 1 million soldiers and sailors in that conflict right here on the continental United States. We had the Union Army up north and the Confederate Army down south, and Lincoln at the time was trying to reunite the country. So he said, hey, let me create the VA, and regardless of where you served, in the Union Army or the Confederate Army, our nation has an obligation to take care of you. So he did that. Simultaneously, though, he also reached out to all the governors at the time and said, I'd like to create the State Veterans Home Program. And what that, believe it or not, we are the oldest program in the history of American government between Washington, D.C. and all 50 states, and as well as the Commonwealth of Puerto Rico at this time. So the State Veterans Home Program, we receive funding from the VA, but each of the 172 homes across the country is owned and operated by their state. In the case of my home, we're owned and operated by Stony Brook University, and that's who my governing body is at the end of the day. For those who live in other parts of the state, the next closest state veterans home is in St. Albans, Queens by JFK Airport. We have one in Montrose, which is the Tarrytown, Sleepy Hollow area in the Hudson Valley. Batavia has a home, which is near Buffalo, and Oxford has a home, which is near Binghamton. All told, we're about 30,000 beds nationwide. And why is that important? The VA recognizes the State Veterans Home Program as the largest provider of long-term care to our nation's heroes. So who are we and what do we do each and every day? Our home is located right on the campus of Stony Brook University. For our veterans in the audience and for people who might have a parent or grandparent who's a veteran, we offer short-term rehabilitation. Maybe the veteran has gone for a knee replacement, hip replacement, open heart surgery. We can do that short-term rehab. We offer traditional long-term care, and I think some of you might recognize the ADLs, or activities of daily living. When you suffer from trouble with 2 or more of the activities of daily living, that kind of puts you in the role of nursing home care. We can do a mini test right now real quick. Reggie, can I do a test on ADLs right here? Okay. How many people in the room actually, when they woke up this morning, were able to get from their bedroom to the kitchen without assistance? Pretty much everybody. How many people can feed themselves, no problem? Okay. How many people can toilet themselves, no problem? Okay. Who took a bath in the last 48 hours by themselves? No assistance? Half the room. Okay. So those, we kid around, but we call those activities of daily living. We can think about maybe our parents or our grandparents who suffer from some of those issues. The 6th issue, believe it or not, I didn't mention dressing. I'm not going to go into everybody's fashion style today, but dressing is also a key component for activities of daily living. When someone suffers from 2 or more of those activities, it's time to consider skilled nursing care. There is a 6th issue that we are concerned about, and that's those who might have some kind of Alzheimer or dementia who can't really provide or do medication management on their own. So that becomes a very big deal as well. In addition to long-term care in the form of a skilled nursing facility, we also have a very unique medical model adult day healthcare program. And what does that mean? We have veterans who come in from the community. By law, they have to be able to get there within a 1-hour drive time. And we provide all the services of a nursing home within a 6-hour span. So that includes breakfast and lunch. That includes any kind of rehab, occupational therapy, physical therapy, speech therapy. That includes any kind of podiatry care, dental care, optometry care, certainly vital sign checks. And people keep their own doctor in the community. So if the doctor says, hey, this particular veteran woke up with a 100 fever, we don't say stay home. We say come on in, and we try and provide services to that veteran as well. So it's a great program, and when you think about it, it's even greater for the caregivers at home. So let's talk a little bit about the healthcare challenge. I think I revealed to you, certainly Morgan indicated my background, but I spent the first 18 years on the hospital side of the business, the acute care side, as we say, versus the post-acute care, which is certainly the long-term care side. As a healthcare hospital administrator, I always had to worry about quality of care. Quality of care. And it's hospitals, as you know, are busy places. We have emergency rooms, we have operating rooms, we have labor and delivery rooms, we have every kind of ICU that you can think of, and it just tends to be a very big, busy place. But when I came into the world of long-term care, it's a little bit different. You don't have as much action, and most people get in through the admissions department versus the emergency room. But as a healthcare administrator now in the long-term care world, I have to worry about quality of care, but bigger than that, I have to worry about quality of life. And that's where art therapy comes and plays a role, certainly in the long-term care field. So when you think about it, for some of our veterans who come to the home, this could be their last stop before they meet their maker. And it's my job, whether they have cognition or very little cognition, to make sure that we take care of them and then they have the fullest quality of life. So in terms of the role of the therapeutic rec, and I can speak for my home and others, we try to emphasize on the whole person wellness. We're trying to support emotional, social, physical, cognitive health to enhance overall quality of life. Now, I didn't mention this, but probably about 50% of my clientele, today's occupancy was around 320 veterans. About half of them suffer from some form of dementia or Alzheimer's. But 25 of them I keep in a special unit. It's my memory care unit. And these are veterans who tend to have elopement behavior. These are veterans who families tried to care for themselves, but maybe while you're driving on the parkway, you see those silver alerts because grandpa made it out of the house, got the keys to the car, and now he's driving and nobody can find him. So there is an element of veterans with that kind of memory loss, but also elopement behavior, and then we try and provide a safe environment for them in our memory care unit. We do personalized care plans. Anybody who comes in, we tailor programs and treatment approaches to each resident's unique leisure interests, what their abilities are, some of their preferences to encourage engagement and fulfillment, and everybody's different at the end of the day. When you come into the home, one of the great things we do is we provide you with an iPod with your favorite genre of music. So, you know, you might be classic rock, somebody else might be jazz, somebody else be hip hop. Whatever it is, we try and customize it for the veteran so that he or she may have that ultimate veteran experience. We talk about the power of art therapy, where we foster creativity, self-expression, emotional healing through art-based interventions, while also promoting relaxation, cognitive stimulation, which is very important, and opportunities for meaning connection, maybe from the residents who live there. And by the way, we call people in nursing homes residents. We don't call them patients because they kind of live there and it's their residents. We try and make that connection among their own family members, among their peers in the nursing home, and certainly with our staff that cares for them as well. We believe in a holistic engagement. We like to combine recreation therapy and social activities to nurture a sense of purpose, a sense of belonging, and a sense of joy. And for those of you, I'm going to take a group from the MHA program. They're going to be visiting us in a couple of weeks. We want them to understand the culture of the institution and why people come to work as employees and why people thrive there as residents of the home as well. So we have a lot of expertise, and this is a little unusual. I'm a little unusual too in terms of who I expect to work for us in terms of their quality. But we have a credential in the world of rec therapy called CTRS, Certified Therapeutic Rec Specialist. Most nursing homes are blessed to have one CTRS work for them. It's usually the director of the department. But in my home, all 8 of our rec therapists have that credential. And we said that if we're going to make a commitment to quality of life for those who we serve, then we need the credential to back up who's working for us in terms of the employee. We also have 2 licensed art therapists as well, and we have 2 licensed music therapists. And bigger than that, too, while I have 600 employees very dedicated to the mission, I also have 200 dedicated volunteers. And many of the volunteers are veterans themselves. And I love asking the veterans why they volunteer. And here's what they tell me. I'm making an investment to my future, you know, should I have to be here at the Long Island State Veterans Home. So it's a wonderful circle of life among our veteran population, those who served in the Army, Navy, Air Force, Coast Guard, Marine Corps, and now the Space Force. So very dedicated group of people. So we try and engage in programs that heal and inspire. Programs are designed to support all aspects of wellness, social pet therapy visits, live entertainment, community outings. It's not unusual if we take a group of residents and we'll charter a fishing boat, or maybe we'll take them to Citi Field to see a baseball game. We're very fortunate on our campus to have the Stoller Arts Center. Many of our residents enjoy music and theater. We're able to provide that to them. We also do food events in the community. But the number one popular trip, does anybody know the number one popular trip among our veterans? Would somebody like to guess? Red, you want to take a guess? No, it's not the Yankees. It's Walmart. What the hell's going on at Walmart? I don't know. What happens is many of our veteran groups provide our vets with a gift card for $25, and that's where they get all their contraband while they're out in the community, and we have to check their bags when they come back. So, but it's all good, and our residents are part of our community, and we want to get them out there in the community. In terms of creativity, we have many art therapy projects. We have many music programs. And we do a lot of live entertainment. It's not unusual for something to be happening at the home at 10 a.m., 2 p.m., and 7 p.m. Those are the times that we engage with outside entertainment as well. We do something special too. We do cognitive programs. So we have a sensory room. We have a snoezelen room. Snoezelen is a Dutch word that means different. Help me out here, Deb. Yeah, sensory perception. So when you go into that room, you might be a little agitated, but we can calm you right down. We put up a screen like this and maybe show you a video of a beach, and then through aromatherapy, I can put the smell of a Coney Island hot dog or maybe some suntan lotion. My employees don't call it the snoozelen room, they call it the Woodstock room, especially the older employees there, because we can take you into a different place, a better place, and we can just calm you down. And it works very well, and we've seen a tremendous reduction in the need for medication for some of our more agitated residents at the end of the day. We also have virtual reality. That came to the home about 5 years ago. That has been a big boon. You need to know that in the State Veterans Home program, our fastest growing population is the Vietnam veteran who served back in 1969. Our Vietnam veterans are currently between the age of like 77, 78, and some of them in their mid-80s. But they had a very horrible experience and were not welcomed home properly like our other veterans in this country. And that exposure to Agent Orange gave them all kinds of medical illnesses, including a lot of cancers and a lot of neuromuscular illnesses. And that's where drug use became very big within the military during the Vietnam War. So a lot of them have PTSD from their activity, and it's our job to try and provide them non-medication type therapies to get them to a better place. And I have to tell you, the virtual reality has been a tremendous program. If anybody in the room here is an active bowler, there's a group out there called BVL. It's the Bowlers to Veterans Link. And most bowling alleys across the country, they raise funds for our veterans. And the specific purpose of their raising money is to provide funding to both VA hospitals and to nursing homes for therapeutic rec purposes. And BVL has given every 173 of the state veterans homes scholarships to provide virtual reality in their nursing homes. So this is a very big deal. It's a multi-million-dollar project. And they came to us as the first home in America to say, could they pilot the project with us? We did it for about 2-3 months. It was an immediate success, and we shared that program with other homes around the country. So we're always looking for the latest and greatest thing. In terms of physical, we talked about outings and getting people out of the building in active recreation. And believe it or not, spirituality is a very big deal in the nursing home setting as well. When you reach late 80s, early 90s, I just see an incredible increase in spirituality. So all the Catholic guys are going to Jewish services on Friday. All the Jewish guys are going to Catholic Mass on Sunday. Everybody's trying to get good with their Maker before the ultimate end. So we see a lot of that, and we do a lot of our programs. As a organization, on payroll, I have a half-time priest, a half-time Protestant minister, and a half-time rabbi as well. So it's a very important piece. Each program offers opportunities for veterans to connect, to express, to grow in very meaningful ways. And certainly you see some of the slides. Okay, oh, I'm getting the hook. Hold on. Creative expression. I just want to show you. We participate in art programs, believe it or not. Our art therapists are very busy. And Greater New York Hospital Association has an annual calendar. And we compete against all the hospitals in the New York City area, as well as nursing homes. And these are samples of drawings done by our veterans at the home that have made it into the calendar. And then again, the role of art therapy in a clinical setting. We want to create meaningful experiences, provide opportunities, want to help veterans and their families find and reconnect for joy, purpose, and community. I can't tell you, especially among our Vietnam population, how much disconnection sometimes there are from families or those who served in battle when they come back. Sometimes the man or woman returns very different, and it's our job to reconnect those families. We try and create lasting heirloom memories for families as well. Think about some of these photos, some of these drawings, some of this artwork. The veteran might pass, but the family gets to keep that as part of their memory. We do a lot of, one last slide, we do a lot of contests too. Very excited, October's coming, and we have our famous pumpkin carving contest. In the spring, we do our Easter egg. We take a big wooden piece of wood shaped like an egg, and everybody competes in terms of their artwork. And it's the talk of the home at the time. You can feel the vibe at the nursing home a week before we have to pick the judges and pick the winners of those different contests. So it helps with our culture. Lastly, thank you for the opportunity to be here. I look forward to answering any of your questions. And thank you to Hofstra University, where I've been an adjunct professor here for about 33 years, and I've loved every minute of it. Thank you.
Thank you, Fred. I can redirect clients all day, but I have a very hard time cutting presenters off, and I'm really impressed that our panel has so much rich content in such a short amount of time. So we have our last panelist coming up to the podium. Dr. Deborah Elkis-Abahoff is an associate professor of our very own Creative Arts Therapy Conference program at Hofstra University. She holds creative art therapy licenses in both New York and Connecticut, as well as a psychology license in New York and a certification as a clinical trauma professional. In addition to teaching at Hofstra, she is also a psychologist with America's Vet Dogs through the Guide Dog Foundation, often bringing dogs in training to programs and conference events. Just like today, she does have a special guest, Luke, who is on duty. I did ask. Dr. Elkis-Abahoff's research connects art therapy with medical illness, neurological responses, and veterans, in addition to co-editing the book, Art and Expressive Therapies Within a Medical Model, Clinical Applications. She holds an appointment at Northwell Health System's Feinstein Institute for Medical Research as an assistant adjunct investigator in the Center for Neuroscience. And additionally, Dr. Elkis is the recipient of Hofstra University's Dean Grant in 2016, the American Art Therapy Association's Raleigh Silver Research Award for Outstanding Research in the Field of Medical Art Therapy, also 2016, and the recipient of the American Art Therapy Association's Best Paper Award in 2019. She's going to help deepen our understanding of art therapy with the veteran population, and we welcome you and Luke.
So that's Luke. Hi, everybody. I want to, first of all, introduce my co-presenter, which is Luke. And he's trained service dog through America's Vet Dog, as Morgan had said, which, just so if you don't know, America's Vet Dogs trains and provides service dogs for veterans with physical disabilities, or combat-related PTSD, as well as first responders. They partner it for them for free, and there's a lot of volunteer work. So just to get started in how I became involved with veterans was I became a puppy raiser for a guide dog. And on the time, I raised a couple of dogs, and some were on campus, some were in classes, some of my students remember, faculty remember. I ended up being asked about, you're a psychologist, and we need somebody to help out with our veteran applications, which started to say, okay, I worked with veterans. I actually worked at the Long Island State Veterans Home way back in therapeutic recreation as their art therapist, and I did work in the memory care. And I worked with veterans here and there throughout, but this was the first time I was really getting involved with the veteran population. And we talk about beauty. There's the beauty in the dog, there's beauty in the partnership, and there's really the beauty in getting to know veterans and what they have done for us, our country, and their whole philosophy in serving. So what I wanted to do today was to really start with discussing the culture of veterans, of military. So as we see, we have the Army, the Navy, the Air Force, the Marines, the Coast Guard, and Space Force. So we have 6 different branches, 6 different cultures. So what does culture include? It includes the values, norms, and traditions that affect how individuals of a particular group perceive, think, behave, and make judgments about their world. Beliefs about the military are involved with discipline, teamwork, loyalty, having a higher calling to serve, self-sacrifice, and the fighting spirit. So to look at the veterans and getting to know their cultural belief system and how they negotiate, how they believe, it's really important for us to understand if we're going to be working with veterans. There are the tenets of the warrior ethos, selflessness, loyalty, stoicism, moral code, and excellence. But those have both strengths and vulnerabilities. So the strength of selflessness would be placing the welfare of others above one's own welfare. But we have to remember there's also a vulnerability in being selfless. And that is not seeking help for health problems because personal health is not your own priority. Loyalty, the commitment to accomplishing missions and protecting comrades in arms. But then again, on the other side, we deal with survivor's guilt, complicated bereavement after loss of friends. Stoicism, toughness and ability to endure hardships without complaint. Once again, there's another side. Not acknowledging significant symptoms and suffering after returning home. Moral code, following the internal moral compass to choose right over wrong. But it also leads to feeling frustrated and betrayed when others fall short of following that moral code. And then excellence, becoming the best and most effective professional possible, or sometimes there's feeling ashamed of their imperfections. So as you can see, when we're working with veterans, there's a very strong code and ethics and all of that, but that also leads to vulnerability and issues with how we interact as therapists, as art therapists. So when we're working with veterans, we have to understand veterans, right? So you don't have to walk a mile in my shoes, but you have to know I don't wear shoes. I wear boots. So it's understanding the terminology. For example, if somebody's in the Army, they're called a soldier. What do we call someone in the Air Force? Are they a soldier as well? Anybody? Okay, so I'm going to go through. The Army is a soldier. The Navy is a seaman or a sailor. The Air Force is an airman. The Marines, they're Marines. Don't want to mess with the Marine. I'm married to one. The Coast Guard are coasties or guardians, and Space Force are guardians. So you have to meet your clients where you are and know their language, okay? So if I came into a session with a new client and he was from the Army and I said, so what was it like to be a soldier in the military? Do you think I would be able to keep him engaged or her engaged in feeling trust for me and saying that I understand? So really important for us to get to know our veterans, the terminology and where they come from. So mental health providers, there's only 6% of mental health providers that serve veterans who served in the military. Okay? So the DoD, Department of Defense, and the VA, Veterans Administration, cannot provide enough therapists. There are 8,000 psychologists and social workers in the DoD and 24,000 in the VA. The problem we have is there's constant hiring due to turnover. It creates an inconsistent amount of treatment. So we have, I talk to veterans so often, they say, I've told my story 5 times and now I'm waiting for another therapist. So we feel that there's this gap that needs to be filled. In addition to that, when they're not getting consistent treatment, we have a risk of suicide, which among veterans is 22 suicides a day, average. As part of the mission for mental health is to break through the stigma, create a safe space, provide consistency, and allow creative expression. So this is where the art therapy impacts. Okay. So art therapy offers veterans a powerful, creative way to cope with mental health challenges like PTSD, depression, and anxiety by providing a safe space to express difficult emotions, process trauma, and promote healing and self-discovery. Through art making, veterans can develop new coping skills, improve physical and cognitive functioning, and foster a sense of community with others. The VA offers creative art therapy programs, and many other organizations also provide therapeutic resources for service members and their families. I will say we need more art therapists in the VA. Not every VA does have art therapists on board, but when it is there, it is very powerful. So today I'm just going to talk really quickly about a project that was developed that we are planning on initiating and making happen. So this is where the art and the veteran comes together. We do from words to art, transitioning from war to civilian life, which is really a big hurdle for many military people to transition from their military lifestyle into a civilian, different culture lifestyle. The research team consists of me, Morgan, who's back here, Yiddy, who is our military person in the audience earlier, Peter Lattori, and Katrina Morse. I don't know if Katrina's here. Hey, Katrina. Okay. Together, we started developing a pilot study to examine the impact of the humanities approach to narrative and visual expression in supporting combat military veterans who are transitioning back to civilian life. This study aims to explore how engagement in the narrative and visual expressions has on veterans hope, self-esteem, and social and personal identity. what we did was we started with the narrative. If you look, I'm not going to read all these words, I promise, I promise. You can read some of the words while I'm talking. So we took a list of words. We wanted to get the group really engaged with connecting to that terminology, those words that have to do with the military, with their experiences. Pick out words, talk about which words spoke to them, and think about what they mean. Then we are going to have them do a little bit of a writing, but first we're going to give them a prompt. So I have two poems here that are our narrative examples. Elise, do I have time to read them? 2 minutes? Okay, well, I'm not going to read them. Well, actually, take a minute to look. But really, it has to do with the importance of the veteran, they soar in jets above land, they sail beyond seas, they march across the desert and crawl between the trees. It's really talking about the military experience. And then it talks about how we should be honoring our veterans. After we do that, they're going to go off and they're going to do a writing of their own, whether it's a poem, a narrative, any kind of narrative expression of creativity. Then we're going to show 3 pictures, because we're going to start to get into the visual, of military art. This is military art by George Withers. He's a professional artist. He was a professional artist, illustrative reporter, and he was a Hofstra alumni back in, Morgan, do you remember, 66? Mid-60s, we'll go with that. So he has these pieces of art that are very, let's sit around, let's talk about them. What do you see in them? What is happening? And then we have our group go back to their writings and be able to do a visual based on what they wrote so that they can express themselves in a more visual, creative way where words aren't able to express what they want to say. So I have, in the next slides, I have artwork, and I'm almost done, artwork created by a veteran. Here we go. This is the first one. So the following examples are artwork created by a career veteran who served during September 11th at the World Trade Center and was deployed to Iraq during Operation Iraqi Freedom, which fondly known as OIF. These are visual representations of transitioning to civilian life and attempting to both incorporate his experiences while still holding tight to the memories and struggles of the losses that he experienced. So this is the first one, and we can, start asking, and I'm not going to do that because I only have like 1 minute left. We can start asking, what reaches out to you? What do you think that person there is feeling? How would you feel if you were in that piece of art? What would be your experience? So I have a couple of others. This is his second piece. This is a veteran same veteran, but he's the veteran who told me about the art saved him while he was in Iraq, because that's where he started doing his artwork. And when he came back, he has been very involved in the art experience as a therapeutic approach. So these are powerful images. And then the last one I have is of 9/11 and his experience. So that takes that a little bit out of the military being deployed, but it was actually right here, national land. So that is it. I will hit to Q&A. Okay. Thank you. He did a good job, right? Good dog. Good boy.
Excellent. Okay, let's give our lovely panelists one last round of applause, as that was a lot of ground to cover. And they did so beautifully. Let's see. Okay. So we do have time for a couple of questions. If anyone would like to come up to the front stands where the microphones are, you're welcome to ask a question and let us know if it's specifically to one of the panelists. Or Luke.
Oh, Luke. Luke can answer questions too.
Never mind the people behind the curtain. We have a question coming up. Oh, she's leaving.
Question?
We don't know.
Yes. Skylar, thank you.
Okay. To Dr. Elkis, you said there's a high turnover rate for mental health providers with veterans. Was there ever a time when you thought about doing the same or stop working with that community?
Yesterday?
Yeah, yesterday.
That's a great question.
No, that's a great question. Had I gotten involved with the veteran community earlier on in my career, it would definitely have been a direction I took. I find that the veterans are such an amazing population to work with, and they have given so much, and they need so much, and anything that we can give back. And it's heartbreaking to hear how much turnover there is when I speak to my veterans and they say, I had a really great therapist, but they transferred to Alaska, and I don't have anybody right now. I'm still waiting to be assigned. And then they have to tell their story again and over and over. So, yes, I would definitely consider going in that direction.
Thank you.
But I wouldn't give up teaching you guys. I love you guys.
No, she can't go anywhere.
I think the other thing that you should realize is the VA has incorporated telemental health. So while somebody might be transferred to Alaska, there's always a chance that through telehealth that you can maintain that therapist.
Yes, some of them do.
Yeah, the problem is with the frail elderly population, it's very difficult if you have a hearing problem or a seeing problem, a vision problem. That always doesn't work at the end of the day. We find out that in the state veterans home population, only about 30% can take advantage of telehealth. So,
I was going to say, do you see a difference in that accessibility with the residents and clients, or is there still a preference for the in-person?
I think there's always a preference for the in-person. What we have to worry about is every time they have to see a specialist, I'm trying to avoid them being in an ambulance for 2 hours to get to that clinician. So if we can pull it off through telehealth, we try and do it that way.
The big setback with telehealth with our veterans is the veterans with PTSD who have issues going into the community. It's very comfortable to stay at home and do telehealth and not have to get out. So they're doing their therapy, but they're not experiencing their continuation of their functioning in those areas. So it's a double-edged sword.
Great. Thank you. Great question. Next.
Hi, I'm Amy Solomon. I work at the museum here on campus, and I'm really interested in the idea of social prescribing, and if that, factors in, with you're talking about shortages of therapists, and the idea that medical professionals, general practitioners could prescribe art interventions to people who maybe would come to a museum for some art therapy or to a community center. Where do you see creative arts therapy and social prescribing kind of merging?
Yeah, I'm going to go ahead and take that because we also are lucky enough to have a museum program down at Florida State, and we have a lot of colleagues who have graduated from our program who continue to engage in the museum settings. And so we find ourselves more involved with community settings. It's an interesting turn, social prescribing. I think that's certainly a major piece of it. We find ourselves in areas that can reach the most people. So we're finding ourselves in museums, in galleries. We're finding ourselves in the community in these different settings. What I would recommend is reaching out and taking a look at the writings by Carolyn Brown Treaton and Ashley Hartman, and they've done a lot of really good work on the value and benefits of art therapy paired up in museum settings.
Thank you, Amy. Hi, Cass.
Hello.
Hello.
Hi, I have a question for Dr. Park. So I love your panel, and I deeply resonate with what she said about being in the state as a minority and coming back to her home country, and it became the majority. So my question is more like a very general question, but I'm just like curious to know that. So based on your research that you did in Korea, now you're back in America, how do you see yourself applying for what you find out in your research into, I guess, what is going on in this country right now? It's a big question.
It's a big question.
Again, I love this country. That's why I'm
We
back.
have 2 hours, 3 hours, right? We're good.
Thank you. That's a really great question because, as I said, I feel like I'm always like building on like my previous research. You know, you're kind of building up your past as a researcher. So one study that I'm doing right now is to work with East Asian international students in Hofstra and how art therapy can help their acculturation process, but from an intercultural perspective, so not multicultural. So I want to value like what they're bringing to this country as well, and I think it's my way of giving them their own voice too through art therapy, and it is my hope to extend this to other international students or like use that as an opportunity for us to kind of learn about each other and to coexist. So that's definitely at the core of my research project. So did I answer your question? Yes. Thank you.
Excellent. Great questions. We still have some time. Excellent. Hi, Callie.
Hi. First, I want to say thank you for all of the information and insight, but I wanted to ask if any of you have had experience with dance in addition to art, like any movement and things like that.
Yes.
Can you explain a little more?
Ireland.
Yeah,
Oh,
the
yeah.
Ireland elective.
We've actually, we've done a lot of work. At the national level, we certainly pair up with our sister organizations, the Dance Therapy Association, Music Therapy, Drama Therapy, Bibliotherapy, and we belong to the National Coalition, Creative Arts Therapies Coalition groups. I'm lucky enough down where I am. I feel like an FSU commercial, but we have a school of dance down there, and right now I'm partnering up with my colleagues over in dance to bring movement and the arts into certain correctional environments. And so we're actually providing dance and movement for juvenile justice programs, reentry programs, all through this new institute that we've just started on the arts and art therapy within prison. So certainly dance has become a major component of what we're doing.
Can I also say, do we have time?
Yeah.
Yes.
We're
I haven't
dance
been
around
flagged
that?
yet.
Is that-
A few minutes.
So thank you for the great question. I also come from like expressive therapies background too, so maybe I can answer a little bit about what you're curious about. So in New York, under the license of creative arts therapists, there's art therapists, music therapists, dance therapists, and also expressive therapists who does everything. But I think it's important for us, like as an art therapist program, like we need to know our boundaries too. But then it becomes tricky because there's no clear line that, you know, like when we're thinking about like a painting, we move our body, so there's like a dance piece to it. So we can't really separate from the ideas of how the movement is going to affect us or our clients, but then at the same time, we're not dance therapists either. So I feel like it's always like being aware of our boundaries as our therapists, but also understand how it can impact, you know, the movement in our clients' bodies, because it does. So, yeah.
Staying within the scope of
Right. So you
Which is why we
understand
partner up.
how it affects each other, but then at the same time, you want to stay within what you're allowed to do, what you're trained to do. That's the better word.
And sometimes pulling that discipline in if
Right.
it's accessible too, because movement really is such a natural part of creativity in general. And it's natural to each person differently as well.
And I would also argue, we have a tendency, not argue, I would present that it's not just dance therapists, but dancers, dance facilitators, arts facilitators. We do have a tendency to become overly territorial as fields as well, and we live in our own silos. And I do think that we stand on the shoulders of those that came before us, which were the artists and the dancers, the movers and the musicians. And so we can partner up with those who are facilitators as long as we recognize the difference between the therapeutic value of what we're doing in the arts as compared to the arts therapies, and just understand those dynamics, and it'll create a plethora of offerings that we otherwise have kind of limited ourselves to.
And something as simple as doing a movement or something at the beginning of an art therapy to get them in centered or get them into a feeling of their body and stuff, and then moving to art kind of brings those two together very simply without really going out of the scope of what we do.
Yeah, read Janie Ryan's work, The Gestalt Art Experience, and she engages in all of the senses and all of the movements as part of her work.
Thank you.
Excellent. Thank you.
That really was a homework assignment. You're required to do that.
No, these are great questions. I think we have time for one more.
Is it?
Kat?
Hello, panel. Thank you so much for being here. It's really cool to see your professors on this panel giving such insight on what the future of our field could look like. So thank you for being here. I wanted to address a point from what Dr. Park had mentioned about balancing minority and majority identities, and I thought that was really powerful. So I wanted to open this question to the panel. I wrote it down here so I wouldn't forget. And I wrote, how can you pursue balancing here in America with the diverse group of majors that we have here? How can you balance without diluting or erasing the particulars of the individual experience while creating this homogeneous experience?
I have a confession to make. I don't know if you know this or not. I'm a white man. And I bring that up because I think, and of course, I just realized what I did, which is I started answering first. So let me recognize that action, but also know that one of the things I've had to learn over 30 years is how, believe it or not, to shut up and to pay attention and to recognize where I am and who I am and what my space is and what I'm learning. And that's something that in this day and age, especially, again, I'm in Florida. And so there's some interesting dynamics that are happening down there, but we're still holding on to this recognition of being able to pay attention. Lavinia Jackson has written a beautiful book on cultural humility and finding the space and the voice. And she wrote a wonderful chapter that we decided to move to the very first chapter of the new Wiley Handbook, because that needs to thread its way throughout the entire volume. All 101 chapters needs to recognize the notion of the multiple identities that are pervasive in our field, and knowing that it's not just the white European voices that started. It's because they didn't start it. There were voices that has since been silenced, and we need to give voice to those again.
Can I say something?
Yeah, you can say
Yes.
something.
Thank you, Kat. And thank you, Dave. Again, I think your question just reminded me again of what the participant said in the first study that I presented, and how they learn through the collaborative art therapy work that coexistence is about coming from different backgrounds and staying together. I really think that's so important for us to stay together, despite the different backgrounds and values that we have, we still can stay together. I think the conflict there will be conflict, but I think it's a very natural process of us finding a way to stay together. So as long as we don't walk away from it, I think there's a chance of staying together longer, I guess. So yeah.
I feel like it's so important to hear everybody's voices and have all the opinions, because that's how we learn, that's how we grow. So everybody gets a seat at the table and has their time to share and to speak and to learn and to grow together. So that's...
And on the healthcare side, hospital care or nursing home care is a team sport at the end of the day. I will tell you, from my 600 employees, I probably have over 400 in terms of the diversity. But I think when you come to work each day, committed to the mission, the vision, the values, and understand what the nature of your work is. And for the students here, it's nice to get a paycheck every 2 weeks, on time, every time. But go to work someplace because you believe in the mission of the organization. So my job as a leader is to make sure I create that mission and who we take care of, the veterans. You know, military was pretty much colorblind at the end of the day. Everybody had to help everybody, and a lot of our veterans were in combat situations where they didn't care about the race, gender, sexual preference of the person next to them when they were in the heat of battle. So I think we're blessed from that perspective in who we care for, and they don't see that. But as a leader, you know, your job is to make everybody feel included, as long as we are committed to the mission, the vision, and the value. And I think that's very important in today's society.
Absolutely. We're all in it.
Thank
We're all in
you.
it together.
Well, let me understand something.
And-
You get paid for what you do?
I do get paid.
I don't.
What's this two?
How's this
We'll
happening?
we'll end on the positive that we get paid for what we do. Thank you all so much. We're out of time, unfortunately, but please do research, learn more, reach out. Thank you all for your time.
And-
Thank you, panelists.
Thank you.